business, amblyopia, genetics, nutrition, vision, coding and billing for vision therapy, and neurorehabilitation. In 2002, he was awarded the Tennessee Young Optometrist of the Year. Dr. Clopton attained Fellow of the College of Optometrists in Vision Development in 2006, diplomat in the American Board of Optometry in 2013. He's a former board member of College of Optometrists in Vision Development, Tennessee Brain Injury Association. He's past chairman of Vision Rehabilitation Committee for the American AOA. He wrote AOA guidelines for coding and billing for vision therapy and neuro rehab. He's a co-authored Optometric Management of Functional Vision Disorders and the Optometric Practice in the book Visual Diagnosis and Care of the Patient with Special Needs, first edition. He's also a U.S. patent holder for system and method of real-time monitoring and dynamic treatment of oculomotor conditions. I won't read the patent numbers though. Granted September 2014. He has become a SSI licensed scuba diving instructor in 2021. That's super important.
Yes, it is.
I'm so happy to have my friend and colleague, Dr. Clopton, lecturing for us today. This will go 2 hours, and we will not probably even get to the 2 hour mark. We will probably end close to the time of 11 that we had planned on, maybe 11:05. Okay, thank you so much. I'll turn it over to you.
Thank you.
Yes,
all right.
Thank you so much.
Okay. Wow. I'm really something on paper. That's pretty good. So I have no financial declarations. We're going to talk about genetics today, or what I like to call applied cellular biochemistry, because I have learned so much from wrinkle peas and smooth peas that it's amazing what we are learning, and this field is exploding. And when I say exploding, I mean it is. I read 10 studies a day, and I can't keep up, and that's just in optometric or ophthalmic stuff. So I have no financial declarations. Today we're going to understand the basics of genetics and genetic testing types. We're going to learn about overall genetic effects on eye disease and conditions. They made me stick to ophthalmic stuff with this, but there is so much systemic things that go along with it. And we'll delve into those, and we'll see where it applies and how you can improve your patient's outcomes. We're going to learn to apply genetics to ocular disease and how they can play a role specifically in ocular conditions like glaucoma, dry eye, macular degeneration, whoop, whoop, the biggies, right? So everybody loves those. So we first sequenced human genome in 2001, and there's a lot of things that have happened since then. We have learned that things that we thought had no effect on different areas have huge effects. So we'll talk about that a little bit. So our genetic code is 20 amino acids. We have 5 billion letters. You remember the ACGT? That's it. That's all we get. But those combinations code for 30,000 genes. Every cell in your body has 100,000 proteins per cell. You think about that one for just a second. 100,000 proteins per cell. Here's some numbers I thought were pretty interesting. The odds of a genetic mutation creating a functional protein are 1 in the 10 to the 164th power. Mind-boggling. 10 to the 80 elementary particles in the universe. 10 to the 16 seconds since the Big Bang. 10 to 139 events, just things that happen. Odds of winning the Powerball, which I was driving in, and it's 500 million for both of them. So start playing, because it's 1 in 292 million. That's pretty good odds, according to the rest of this stuff. Odds of dying in a plane crash, 1 in 10 to the 6th. Odds of dying taking a bath, 1 in 10 to the 5th. That's pretty close, actually. So don't fly planes and don't take baths. Every cell in your body is processing thousands of chemicals all at the same time in synchrony. So we've got these processes, but not every process is efficient. And so genes, if we have a mess up, it should have been ACGT and it was AGCT, okay? That's called a single nucleopeptide polymorphism. we call it a SNP, okay? It's where there's a substitution of a single nucleopeptide, and each variant is present in appreciable degree within a population, okay? So what happens when we have these SNPs? Basically, when we have SNPs, we become less efficient at what we're doing, okay? Whatever that process is, the making of the enzyme, the creating of the protein, it gets less efficient, okay? So we get our genes from our parents. It's more than wrinkle peas, 30,000 of them. We have SNPs that reduce the efficiency. If we're not efficient, we get chronic disease or conditions. And I'm going to tell you that this has changed my whole way of thinking about health and wellness in this world, okay? We can maximize these deficiencies. There are things that we can do about. Let's say we don't make, I was talking to somebody this morning, they said, I have an MTHFR deficiency. That's probably the biggest one you'll hear of. And there's things we can do about that, okay? So how did I get into this? About 15 years ago, I had a patient that is now, gosh, he's in his 20s now. Mom came in and said, my son has severe autism because he has an MTHFR deficiency. And I went, MTHFR? Okay, good. What is that? That's the mother effer. MTHFR. No, it's not the mother effer. It's methylfolate reductase. Anyhow, but I didn't know what that was. And I said, well, okay, I got to figure this out because I have a pediatric brain injury practice that deals with special needs. And I wrote a chapter in a book on special needs years ago. And this is somebody that has something I got to know something about, right? So I went and looked it up, and I said, oh, that's pretty cool. And so from that day, I started getting into genetics and learning about it, and started providing some genetic counseling about 10 years ago with a company called XRMD. It's an ophthalmologist out of Ohio, and we tested 24 genes, including MTHFR. And we said, okay, you've got a deficiency here, and we can give you methylfolate, okay, as a supplement. We can take care of that. It improves it, okay? And so we are discovering new pathways every day. Genes that we thought had one or two functions actually end up being involved in thousands of enzyme cascades. One of the biggies is inherited retinal disease. How many of you are doing the testing for inherited retinal disease right now? So, highly suggest Spark Therapeutics. I've got probably just for inherited retinal disease, I've probably got about 50 or 60 patients that we have tested, and we can tell them you have Beckett's. Behçet's. Say it again. Behçet's. Okay. So you've got Behçet's. You've got a very high likelihood of passing retinitis pigmentosa to your children. You have an autosomal dominant, you've got an autosomal recessive. They are testing 317 genes just for inherited retinal disease. Think about that one, just 317 enzymes in your body, or proteins. These are the ones that they test. I can't tell you what each one of these are. Probably can tell you one or two of them are, but I can tell you that the outcomes are for your patient is that they understand their condition and they understand if they want to pass that on to their offspring. So currently in genetics, like at Vanderbilt, they test for pathologies and diseases and syndromes. This kind of testing is covered by insurance, and they look for, do you have Fragile X syndrome? Do you have this condition? Do you have that condition? At our office, we test for efficiency and functioning of categories of genetics, and then we only test for the things that we can do stuff about. So we can provide nutraceuticals or supplements. We call them nutraceuticals because they are targeted exactly for the enzymes that you're missing. Therefore, they're nutraceuticals. and they have to be guaranteed by a third party that whatever you take, your body is absorbing that enzyme or supplement. So, back in the day, we knew that this was vitamin D. Everybody knows vitamin D is important for all kinds of stuff in your body, right? And we have a pre-vitamin D. We get some sunlight on our UVB radiation. It changes to D3. It's processed in your liver, and we can use it through the endocrine, paraendocrine, autocrine, all kinds of stuff. And these are some of the pathways that we're looking at now. And everybody remembers the Krebs cycle. Krebs cycle's in here somewhere. Folate cycle, methylation cycle, transsulfuration, histamine cycle, neurotransmitter metabolism, oxalate production. You'll recognize some of those with some of the pharmaceuticals that we have out there that either enhance or block these pathways. So, genes are software that make enzymes. Enzymes drive our biochemistry. If we have this sequence down here and we have product A and B and we put an enzyme to it and it produces product C and then goes to product AB with the enzyme releasing. If everything is correct, we make it at 65 miles an hour. So we have this genetic SNP, single nucleopeptide polymorphism, and we have an error in this code and we only produce it at 5 miles per hour. We still produce it. We still produce methylfolate, but it's not produced as quickly or as efficiently as it could be. One of the big things we've found in our office is there's 2 enzymes in methylfolate production. Right now, we have 8 steps in methylfolate production. There's 2 of them called FOLR1 and FOLR2, that is folate receptor carrier genes. Carrier genes carrier enzymes carry the methylfolate from the bloodstream into the cells. So I have many patients that go to their doctor, they get their methylfolate blood levels tested, and they are normal, but they're not producing it efficiently, and they're not carrying it from the bloodstream into the cells efficiently. So it's fine in the bloodstream, but they're completely deficient in their cells. We give them a supplement that has the folate carrier transport gene or enzyme in it, and their methylfolate levels go down in their bloodstream. Okay? Just like diabetes, right? Sugar's in the blood, it's not going to the cells. Folate's in the blood, it's not going to the cells. So, big deal right there. So this is the methylfolate cycle right here. This is the methyl B12 cycle. And you'll recognize, any of you that do any supplements at all have probably heard of SAMe for arthritis, right? You got to take yourself some SAMe. Well, why do we not have SAMe? Because our methylfolate and methyl B12 cycles are not working. I had arthritis 10 years ago. At 43 years old, I had arthritis in my hands. I ride a bicycle a lot, or I used to. Don't ride so much anymore. And I was having difficulty holding on to the handlebars because my hands hurt so bad. I have no arthritis in my hands now, or no inflammation. I didn't have arthritis yet. So what do we get out of SNPs? What do we see in our office clinically? We get autism, ADD, attention problems. There's the biggie, macular degeneration. I'm going to talk all about that, the pathways that we know about right now for macular degeneration. Migraine. I have become a migraine provider in my office. We have 79 out of 80 patients that are doing what we ask them to who have 100% remission of migraines so far. This is in the last almost 5 years, 4.5. 79 out of 80 patients don't have migraines anymore. This is where this hit home for me. I had a lady that was mid-60s, and she came in, she said, I've heard that you're doing good stuff with migraines, ocular migraines specifically. And I said, yep, we do a lot of work with that. And she said, okay, show me. In her 60s, she's been to 20 doctors over the last 30 years. She got 2 migraines a month. off and on, and we gave her a protocol. She started doing that protocol. Part of the protocol was giving her low-dose naltrexone. So if you guys know about naltrexone, you get put on a list. Low dose is 0.5 milligrams every other day. That's the protocol we use. And it has to be compounded, okay? So it has to be called into a compounding pharmacy. So we did this for her, and she moved away to be with her children. And she called me one day and said, "You have to call this into my compounding pharmacy. I haven't had a migraine in almost a year. If I have another one, I will just kill myself." You think about that. They were so bad. And then we got rid of them. She found that relief, and she said, "If you don't do this, I will kill myself." That one went, bam. Wow. All right. So, diabetes, learning problems, glaucoma. I'm going to show you some glaucoma pathways that are really cool that we've just, found out about. So, in the eye, it's intuitive. Glaucoma exists at the level of the retinal ganglion cells, right? We know this. Macular degeneration is at the RPE. Diabetic has to do with endothelial cell dysfunction. Cataracts, autoimmune diseases, dry eye, inflammatory. Everything in dry eye is about inflammation, right? Well, where does inflammation come from? We're going to talk about that. So here's some glaucoma and genetics, and this just came up June of 2020. You remember I read a lot of studies on this stuff. Large-scale RNA sequencing study, 23 subpopulations across 247,000 cells, 312 significant genes for POAG. Think about that one for a minute. That's a lot of information. This stuff, genetic stuff, is being gathered at unbelievable rates. I mean, we're getting so many conditions that have hundreds and hundreds of genes, and there's usually about 5 or 10 that are the key factors that we can sometimes do things about. But that's just one study. So when I was looking at glaucoma, this supplement that I take every day kept coming up, palmitoyl ethanolamide. Everybody know about palmitoyl ethanolamide? Okay. It's a naturally occurring substance, and here's a study on palmitoyl ethanolamide and endothelial dysfunction and ocular hypertensive, natural retinoprotectant, effective, we call it PEA Soothe. PEA, we'll just call it PEA, on interretinal function in glaucoma, visual field damage progression in normal tension glaucoma patients. Here's a significant reduction in IOP with the use of PEA. We're getting about a 4 to 6 point drop in intraocular pressure with PEA. That's huge. Show me something else that's doing that and is neuroprotective at the same time. Palmitoyl ethanolamide and lutein effects. So we were just talking about that this morning with macular degeneration and how palmitoyl ethanolamide can affect that, or they didn't talk about that, but there's studies on it. It's out there. How about macular degeneration? There's genetic mechanisms in ARMD. You can look up this study. I was going to show you these studies, but we're a little late, so I'm going to zip through them, and they're on there. And you can get the slides if you scan the little thing on your registration, and you'll have the slides for this, and you can look it up yourself. Dysregulation of the complement system. So I had to go back and learn what the complement system was. It's immune system. Dysregulation of the immune system has been strongly associated with the development of AMD. All right, so here's some of the complement system and how it works. C3, C3b, factors, blah, 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 membrane attack. I'm not going to go through all this stuff because you don't need to know that, but what you do need to know is that it's associated, okay? So I have a colleague who's not here that I put a patient on rapamycin, which is an antimetabolite, a low-dose rapamycin. And they went to another colleague and they said, why are you doing that? They said, well, Dr. Clopton says that this helps with macular degeneration. And he said, well, I spent the weekend with a retina specialist and he didn't know about that. And so he took her off of this medicine. And I called him up and I said, hey, before you speak about these things that you have no knowledge of, please go look it up, because here's just a few of the studies on macular degeneration and rapamycin. So I think that this is going to be something in the future, and that's one of the things in my practice is I'm not afraid to go ahead and look at this stuff and go, okay, make a clinical decision. This person has the potential for very serious problems with this. Let's go ahead and nip it in the bud. Oh, and here's a few more. So, this is how I think about disease now. And this has been changing over the last 10, 15 years. Patients have errors in their cellular biochemistry. Okay? We get their genetics, we look at those errors. Patients don't have, quote, macular degeneration anymore. Macular degeneration is an outcome. Okay? We have mTOR pathway defects, ATG, there's a bunch of ATGs, ATG1, ATG6, ATG5, ATG16L1, I think, and then the APOE pathways and or complement immune system pathways. Good gracious. They have defects in this, and the outcome is macular degeneration. Or, in this case, the ATGs, dementias. Okay, so the ATGs have a big influence on, and APOEs have a big influence on dementias. So a lot of times when I'm looking at the pathways for macular degeneration, I'm also looking at the potential for dementias. Okay, so pharmacogenetics are two areas. Pharmacokinetics is how the body processes the body's impact on drugs. How fast does your body clear a drug? This cytochrome P450, remember we all studied that in optometry school years and years ago and promptly forgot about it. And then I had to relearn all this stuff. Okay? So hepatic clearance is a big deal because I've done a lot of my genetics, and I found out that if I ever have a stroke and they want to put me on Plavix, I don't clear that from my liver. My body doesn't have that enzyme to do it, and Plavix will build up in my system and keep getting more and more and more, and I could cut myself and bleed out and die. Prasugrel, the old one from the 1970s, my body clears that normally. I can take that drug without any problems at all. Big deal right there. And then pharmacogenetics is how the drugs impact on the body. Where that applies for a lot of my patients is in the making of serotonin and dopamine and norepinephrine and epinephrine. Think ADD, think mood disorders, think anxiety. And so that affects every part of our life. And then we've got epigenetics. That's the study of correlating gene expression with a drug or nutrient absorption or elimination or metabolism. And SNPs can actually increase or more commonly decrease the activity of an enzyme. So we can actually increase our enzymes with a SNP, like my processing of clopidogrel. If anybody wants an example of this afterwards, I'm going to skip this, but this is how we process pharmaceuticals in our body. Do serotonin reuptake inhibitors work for you? Do you even have the enzymes to process them or not? I can't take Toradol. Toradol will do a bad number on me. I can't take dextromethorphan. Yeah, that's it. I can't take that either. Okay, so let's get into the specifics of which ones we're doing. 30 minutes, good. All right, so the methylation pathways, that's one of the people that's influenced me a lot is Dr. Kendall Stewart. He's a neuro-otologist, so he's a base of the skull surgeon, specialty surgeon, brain surgeon. Smartest man I've ever met in my life, and he has a photographic memory of everything that he's ever done ever, and it just boggles my mind. You can ask him a question, he'll go, oh yeah, blah, 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 blah. This is how that pathway works, and this is where it affects, and this is where zinc affects it, and this is where copper affects it, and this is the outcome from that. Really? You know that just off the top of your head? Yeah, he does. Anyhow, he says that methylation pathways are cell-level inflammation. Okay? Can your body get rid of inflammation inside the cell? Neuroinflammatory diseases, optic neuritis, glaucoma, there's all kinds. The outcomes from difficult methylation or methylation that's not efficient is chronic, low-grade inflammation in the body. To me, that's the source of all diseases, right? We look at mitochondrial pathways, APD production. There's a lot of correlation between ATP production in the body and longevity of life. So the end of your DNA, and you've probably heard a little bit about this, is called a telomere. It's the very end of your DNA strands, right? As we are replicating our DNA, the ends of the DNA strands get a little errors in them, and they shorten up a little bit. And then they shorten up a little bit. Throughout life, that happens. And we stop making something. And we reduce the efficiency of making something. That's called the aging process, okay? And as those telomeres get shorter and more SNPs in them, we eventually die. That's how we age and get old. We're going to talk about immune system pathways, autoimmune conditions, which I now classify glaucoma as an autoimmune condition because of all the stuff I've learned. Neuropsych, neurotransmitters, health and wellness. So the current allopathic medical model understanding is genetics cause disease, syndromes, and risks, okay? And right now, a big thing that's happening is we're identifying genetics for drug development. So we're getting drugs that specifically target single SNPs or multiple SNPs or whatever the SNPs are. But right now in our practice, we have things that we can do without pharmaceuticals. All right, so important genes, important SNPs. Methylation, we are currently at our office, and there's more, but at our office we're testing 21 genes in the methylation cycle, okay? Because those are the things that we can do stuff about, okay? So if a patient has a deficiency in methylation, we can give them methylfolate, right? If a patient has a deficiency in B12 production, we can give them B12, okay? B12. So in my lifetime, I have had, in college, I was a competitive cyclist. I was pretty good. But when I got to about as you get higher and higher in the competitive arena, the races get longer and longer. You know, Tour de France, they ride for 5 hours every day. Oh, those guys they're something. So in college, I was good. And I raced, and I won. I won the Auburn Criterium. Go me, right? Auburn Criterium was about an hour and a half race. When I got to the longer races at 3 to 3.5 hours, I could be in the front, pedaling, going, winning, woohoo, go me. And I would have to stop, and there was one time in particular that I couldn't pedal, and I just fell over. And I laid there on the side of the road, and I went, what is wrong with me? Your body stores B12 through food and making it, and you have about 3.5 hours of hard exercise stored in your body all the time. Okay? I hit the 3.5 hour mark, couldn't pedal another stroke because I don't make methyl B12 very well. What's the outcome of that? The outcome of that is DNA and RNA replication. Some of you remember in optometry school, they found a melanoma on my head. B12 was the source, or potentially the source, of that melanoma that I had on my head, along with a few other factors like I don't absorb vitamin D3 correctly. Okay? So that explains, can't be a professional cyclist. Got a melanoma. I've had fatty liver disease all my life until 6 years ago. I don't have fatty liver disease anymore. My liver enzymes were always elevated. Methylfolate and B12. My dad had it. His dad had it. Colon cancer runs in my family. Had that arthritis. So genetics explains all of the stuff in my life that I thought, what's wrong? You know, something's up here. So we removed cellular inflammation. I had borderline high cholesterol. I had borderline hypertension. I don't have those anymore. When I started doing this, my cholesterol dropped 40 points. Why? What is cholesterol? Cholesterol is a marker of cell inflammation. That's what it is. It's an inflammatory marker, right? It's your body trying to get rid of this stuff. So my blood pressure dropped. My everything got better. Okay? So mitochondria, 9 genes. That's longevity of life. Remember the ATP cycle? Yeah, it's a lot more than that now. Autoimmune, we test 31 genes. Autophagy, everybody know what autophagy is? It's okay, I didn't either. Autophagy is the process of getting rid of the garbage, cellular garbage. Every cell in your body takes in stuff, processes stuff, gets rid of stuff. The getting rid of stuff is called autophagy, right? So what's a major thing that we see that is an autophagy-related problem? Macular degeneration, right? I used to tell my patients it's a bunch of cellular debris that builds up in your cells and we can't get rid of it, right? That's what macular degeneration is, essentially. Environmental inflammation. So the nature nurture part, you do stuff every day. Who was up front this morning that had a little bit too much to drink last night? Who was that? Yeah, there you are. Great. Okay. So I'm going to tell you that you may have a little bit of methylation deficiencies, and so that hangover is part of that process. And we're not getting rid of the stuff. We're not processing. So in the neurological area, we test 27 genes, neurotransmitter production and function, which also leads to inflammation and autophagy problem. Women's and men's health, currently 20 genes, hormone risks, metabolic risks, blood clot risks, hypertension risks, pregnenolone, testosterone, progesterone, estrogen cycle conversions, dry eye syndrome associated with testosterone production. When we have a decrease in lacrimal lake, that is often a decrease in testosterone or D3 or omega-3 fatty acids or any number of other problems, or just not drinking enough water. There's tons of causes. So let's talk about methylation. Adding a methyl group to a substrate, it's 250 biochemical processes. It is also used for neurotransmitter production, for cell turnover and repair. That's your DNA and RNA replication. Cell membrane function. Big deal on the membrane. That's where the spike protein attaches, right? On the ACE2 receptor, right? Is that right? Yeah, ACE2. Energy production. Problems with methylation will affect cellular delivery, epigenetics. Almost every cell function in the body is affected by methylation. So if you're defective in the methylfolate pathway or the methyl B12 pathway, you're going to have troubles in the other areas. So here's the methylation pathway cycle. You remember all this? Me neither. I didn't remember all that. You do remember Krebs cycle, right? But goodness gracious, alpha-ketoglutarate, succinate, fumarate, ammonia, urea, arginine, tryptophan, tyrosine, methylene, methionine, adenosine, homocysteine, ammonia, glutathione, taurine. Boy, there's a lot of stuff in there, right? And there's a lot of areas. If we have a deficiency in taurine, we don't produce certain things. MAO, that's a serotonin enzyme that helps us to produce serotonin in our body. If you don't have that enzyme, guess what? Certain SSRIs are not even going to work for you. They just don't work. But we give them to them anyhow. Let's try this. Let's try that. No, let's test and see if you got it, and then we go from there. So there's a ton of stuff in here that actually I've gotten to the point where I kind of recognize them now. So here's the methylation cycle pathway. You got FOLR1 and 2. Those are your folate receptor carrier genes. They transport methylfolate into the cells. You can have normal plasma folate and still not have proper metabolism. Big deal. I've had MDs call me and say, hey, what are you doing putting this patient on methylfolate? Their levels are normal. I said, well, their levels are normal in their blood. You're not testing it in their cells. Okay? They have a deficiency in FOLR1 and 2, both. Dihydrofolate reductase. We'll talk about that in a second. MTHFD, MTHFS, MTHFR. There's the biggies. There's 2 different variants of the MTHFR. And back, I don't know if it's still there, but California and New Jersey actually had vaccine exemptions if you had a MTHFR deficiency. That was when we knew that there was MTHFR. Okay? That was 10, 12 years ago. We only knew about MTHFR. We didn't know about MTHFS and D and DHFR and FOLR1 and 2. So everything keeps growing and growing and growing. So here's that pathway. And if we have a deficiency in DHFR, we can have a 10 to 20% reduction in efficiency. MTHFD, 10 to 20. D1, 10 to 20. Here's the biggie right here. The 667 version of the MTHFR, you can have a 40 to 70% reduction in methylfolate production. That's huge. Can you live with that? Yeah. Can you live efficiently? No. So we've known about methylfolate in birth defects and conception and bringing a child to this world for a long time. This is why. This is the hard science behind all that. So specific genes for methylation, the MTRR. This is methyl B12. Okay. You have an MTRR gene, that's methionine synthase reductase. It's responsible for regeneration of methylcobalamin in the methionine reaction. So you make methylfolate, which makes methyl B12. You can have a deficiency in methylfolate, you can have a deficiency in methyl B12, or both, like I had, and have conditions from that. Okay?
Can you go back one slide?
Can I go back one slide? Yes. So this is the methylfolate cycle, and this is the methyl B12 cycle. This is DNA and RNA reproduction. What do you need out of that?
That's it. Thanks.
Yeah, there's just a ton of stuff.
I'm trying to figure out the source. How are you going to treat them?
We're going to give them methylfolate. That includes,
How about the methyl B12?
we give them methyl B12. But it has to include the enzyme. And here's the differences in supplements. Remember, doctors would say, oh, you take that and you're just
Bingo.
pissing it out, right? Sometimes you are, okay? If you don't have the FOLR1 and 2 and you have a defect in that, forget about it. You just took something that doesn't work for you, okay? That's why you have to have supplements that are third-party certified that they will be absorbed because they have all of those enzymes in them, okay? They have folate carrier enzymes in it. So methyl B12 has a gastric intrinsic factor, and if you don't have that, your body's not going to absorb it when you eat it, okay? Because we do eat methyl B12 out of mussels. Yeah, that's food. That's meat. Sorry. Transcobalamin haptocorin binds to B12 to protect it from acid degradation found in saliva, okay? So here's some more of those cycles. And it just boggles my mind every time I look up some of these images because they get bigger and bigger and bigger and bigger. D3, for example, vitamin D3. 15 years ago, we knew it was really good for your bones, right? 10 years ago, we knew it was really good for your bones and your brain and some cancers. And 5 years ago, we knew that it was involved in about 200 or 300 enzymes cascades in your body. We're up to about 8 to 10,000 enzyme cascades that vitamin D3 is super important in. One of the ones that I get stuck in my head is optic nerve drusen. Little calcium deposits on the optic nerve, right? So what we've found is that D3 with K2, okay, you can take D3 all you want, but if it's not with K2, your body will deposit calcium in wrong places, specifically optic nerve, coronary vessels. So when I see my patients with optic nerve drusen now, I go, oh boy, cardiovascular problems coming up, right? Big deal. All right, so it applies to everything. MTHFR, or methylfolate, applies to brain injury, anoxia, TBI, concussion, neural inflammation, stroke. There's all kinds of things that can cause problems in this area. So one of the things that I do with my brain injury patients is we do their genetics and we start them on a regimen of whatever they need, whatever specifically they need, that patient. All right, next one is mitochondria. It's the highest energy organs and nervous system. This will be affected first. Our retinas, our nervous system, our immune system. So there's 1, 2, 3, 4, 5. There's more than 5 in there. Yeah, 5. Okay. 5 steps in mitochondria production. Ciprofloxacin and quinolones inhibit the first and third steps. They stop that process. Okay? Statins affect all stages. That's why a lot of doctors now are recommending CoQ10 when you take statin medications. What do statin medications do? They reduce cholesterol. What is cholesterol? Marker of inflammation. Okay, so we're taking pharmaceutical to block the markers, not to block the source. Okay, but when you take a quinolone or a statin medication, you are stopping this process. That's why people complain about muscle weakness with the statins, right? Okay, so complex 1, if you have a SNP there, you're going to have a 10 to 20% reduction in function. Step 2, you're going to die. Step 3, if you have a SNP here, it's another 10 to 20% reduction, or you're going to be non-viable for step 2. Step 4, 10 to 20% reduction of the function. Step 5, another 10 to 20% reduction. So ATP production, there's a lot of words in here. That is your overall energy and your telomeres. There's all kinds of stuff with this. So here's a patient that has, this is the way we read some of our results. Genetic result, green, good, yellow. You have green, you have 2 good genes. Yellow, you have 1 bad, 1 good, either way. Red, you have 2 bads, you don't make it so good so much. This patient has a yellow, a red, a yellow, and a yellow. The things that affect that chain are CoQ10. PQQ is polyquinolone. I can't remember what the name of it is, but it's a supplement you can take that is one of these steps. in here. And then magnesium affects that. How many people take magnesium on a regular basis? Right? NADH and calcium affect all that, and ornithine. So here's the biggie. Immune system. Inflammation is good when it's supposed to be there, in healing, in insult, in injury. We have immune system on switches and we have immune system off switches. So people that have defects in their on switches never get sick until they get sick. Then they get low sick. Okay? Off switch regulators, they just never feel good. Their immune system's constantly rolling, too much. I'm going to tell you that. No, I'm not going to tell you that. All right. Sorry, there's some stuff with COVID that is scary. All right. On switches, up regulators, controls C3, controls phagocytosis, inflammation, membrane attack, macular degeneration. CD14, receptor for bacterial polysaccharides, increased risk for gut inflammation. Let's talk about that one real quick. Gut inflammation, you remember the tight junctions? You remember those things, right? They're in the blood-gut barrier, amacrine cells, right? Tight junctions, amacrine cells, yeah. Anyhow, blood-gut barrier, when you have inflammation in your gut, those cells open. Blood-brain barrier, what's it made of? Same exact cells. When your gut is open, that's why they call it your little brain, your blood-brain barrier is open. When things pass through your gut that shouldn't be passing through your gut undigested, it's going through your brain too, okay? Right. Think Alzheimer's, chronic infections, preeclampsia, cardiovascular disease on CD14. Cellular inflammatory on switches, interleukin-13, mostly produced by Th2 cells. If you have a polymorphism here, you have aggressive allergic reactions. Reactive airway disease, those kind of things, okay? And then I'm going to tell you that I do this lecture separately, but dairy is one of the biggest mucus increasers in your body. Cow milk protein specifically, it's called a beta A1 casein, but it increases the level of mucus by double or triple. So if you have mucous membrane problems like dry eye, where their mucous membranes are too much, or they're too thick, they have chronic sinus infections, ear infections, tonsils, adenoids, reactive airway disease, constipation, diarrhea, back and forth, those can be dairy problems. All right, interleukin-5, aggressive allergic reactivity. Think allergies, asthma, eosinophilia for interleukin-5. So some more on switches, interleukin-6, herpetic related. Interleukin-6 is actually turned on by herpes. Increased risk of general inflammation, IBS. Interleukin-23R, highly associated with the JAK2 system. Crohn's, Graves' disease, which means they usually respond to JAK-STAT inhibitors. So if you do these genetics and your patient has Graves' disease, Crohn's, some other kind of stuff, you can call their primary care doctor and say, hey, JAK-STAT might work for this patient. They have the genetic predisposition that they will likely respond to JAK-STATs. Go ahead and give them some. And when you call their primary care doctor and you say those things to them, they go, how did you know that? I say, well, we tested them. Well, how, and then you give them the information on interleukin-23R and say, here's how I found that out. Check it out. All right, interleukin-2RA, increased risk of inflammation. MS. I've got about 20 MS patients, and I'll tell you one specifically because he is my primary care doctor. He is 46 years old and has been on a walker for about 8 years. He can't feel his feet. I've been talking to him about this for, I don't know, 4 or 5 years. I finally got him to take the test last year. I gave him the information, said, go do this. And he said, yeah. And about 6 months later, his wife called me and said, I finally talked him into it, he's going to do it. He called me about 3 months ago and he said, I can't believe I'm saying this, but I can feel my feet. You think about that one. When a primary care doctor calls you up and says, hey, I can't believe this. Interleukin 2 RA with a CTLA4 for MS, type 1 diabetes. Here's an interesting thing. They may respond to daclizumab. And they also need a higher level of vitamin D3 if they got a interleukin 2 RA. TRAF1, tumor necrosis factor. Functions as an off switch. Epstein-Barr infection can induce that problem. So, I mean, this is a lot of stuff to be talking to your patients about because we see this. We see MS. We see type 1 diabetes. This applies to everybody in the world, really. So these are your off switches or down regulators. SOCS1, mess ups there cause aggressive inflammation. STAT4, that's your JAK stats. Tumor necrosis factor, this is a super on switch. It's responsible for being T cell activation. Think coronaviruses. Polymorphisms result in aggressive T cell overactivation. Man, this is a lot to think about right now. I'm thinking about it and going, God. CTLA4, cytotoxic T lymphocyte associated protein 4, chronic inflammation, highly associated with MS if associated with an AL2RA and a VDR. So of my patients that have MS, we've done all these genes, and I have had 2 patients that didn't have these genes. They were good on these. They didn't have SNPs. So I called their endocrinologist, I called their primary care doctor and said, hey, they don't have these SNPs. This could be PANDAS. It could be Lyme disease. It could be something other than MS because they don't have the genetic markers for it. So they started digging in deeper for other stuff, which is pretty cool. I've got this one, DRD2, dopamine receptor 2, high response rate to low-dose naltrexone. I don't take low-dose naltrexone because of my job, but I would likely respond to that, and my immune system would function more efficiently. So broken off switches, or SNPs in the off switches, make you feel bad. You'll have good days and bad days. All right, so the next category is neuropsych. Catecholamine O-methyltransferase. It degrades COMT, it degrades catecholamines, dopamine, epinephrine, norepinephrine. Normal function leads to low anxiety. SNPs in this lead to anxiety, sleep problems, ADD, focus issues. I have a single SNP on my COMT. I take this stuff called Full Focus every day, and it absolutely makes a difference in how I think, how clear I'm thinking. I have quite a few CEOs and other physicians that are taking this because it helps them to think. My next door neighbor is a orthopedic surgeon, and he says he takes the Full Focus on the days he does surgery. So, well, why don't you take it every day then? I don't know. So a COMT defines a personality type. And you can talk about the happy-go-lucky people, the stoners, and the mood disorders all day people. MAOA and MAOB, you remember MAO inhibitors, things like that. Do they work? Do they not work for this patient? Well, it depends on their genetics. Normal function is low risk of depression. SNPs, we don't create as much dopamine and serotonin. MAOA is also known as the warrior gene. These are your people who are your go-get-ems, your type A's. I'm going to get this done no matter what. CEO types. MAOB is X-linked inheritance from your mama. It's known as the depression gene. So if your mama was depressed, you've got a higher likelihood of having that. They both respond to methyl donors, and this is a fun fact. Taurine, choline, methionine, dechiroinositol, DMG, TMG, and 5-HTP. Anybody ever read the ingredients on a bottle of Red Bull? I got patients that are totally addicted to that stuff. Because they have MAOA and MAOB SNPs, the bottle says taurine, choline, methionine on it. So they love, Red Bull gives you wings because it makes you feel good. Sorry, there you go. Makes you feel good. So drink the Red Bull. I love the Red Bull. I've never had the Red Bull. Okay. So this is just some of your pathways for neurotransmitter production. Okay? And there was something I wanted to show you in this specifically. Oh, these pathways are only affected by dopamine, serotonin, epinephrine, norepinephrine, MAO inhibitors, N-acetylcysteine, vitamin D3, B6, B12, sulforaphane, copper, vitamin C, folate, estrogen, magnesium, and anesthesia. That's the only thing that affects this. Recently learned about the association between testosterone and copper. Who knew? And vitamin C and copper conversion of dopamine to norepinephrine. Pretty cool stuff. Okay, so another neuropsych one is called the glutamic acid decarboxylate. It converts glutamic acid to GABA. GABA is your master modulator for neurotransmitters in your brain. Makes you feel good. Normal function leads to calmness, relaxation, sleep, low pain, and seizure problems. SNPs are associated with dysphoria, anxiety, glass half empty, increased pain, sleep disorders, spasticity, low libido. This responds to glycine, zinc, beta-phenyl GABA, magnesium, B6, licorice, chai tea, pho. Who eats pho? Go to the Vietnamese restaurant and eat you some pho. Why do people love it so much? Because it allows your GAD1 to function more normally and you feel calm, relaxed, low pain, low seizure. It's pretty cool. We have whole societies that eat a certain food because it helps them with their lives. Okay, neuropsych, HTR2, receptor for serotonin. Polymorphisms lead to reduced effects of SSRIs. Also linked to lower levels of oxytocin. Oxytocin is released when we have a baby and they nurse. The mother releases oxytocin. Oxytocin helps the kid to bond to the mother. It's our happy you're my mommy neurotransmitter. Prolactin, ACTH, renin, higher rates of refractory depression if you have a SNP. Responds well to higher doses of 5-HTP. I take that as a supplement every day because I have a single mess up in this. So I take 5-HTP every day. Solute carrier family 6 protein A4 transports serotonin from the synaptic space to the presynaptic neuron. Mess-ups lead to reduced efficacy of SSRIs. Higher rates of depression, post-traumatic syndrome, responds well to 5-HTP and oxytocin in women. How cool is all this? Men's and women's health, CYP1B1. Okay, so there is 4 different kinds of hydroxyestrone in the estrogen cycle. Men make it too. Okay, it's not just women, but it's much higher in women. You have a 1-2, which are actually pro-carcinogenic, and then you have a 8-16. And if you don't convert the 1s, 2s to 8-16s, and you take certain types of birth control, you are increasing your carcinogenic hydroxyestrogens. Big deal right there. Had a patient that she was severe special needs patient, and they were putting her on birth control because periods would just mess her up, and she couldn't understand it. And she did her genetics for other reasons, but we had this in here, and I called her OBGYN at Vanderbilt and said, hey, you might want to consider converting her to a progesterone type based one because she has a CYP1B1. And she said, who the hell are you? I said, I'm just an eye doctor that's doing some stuff, and we've just found this. Congratulations, you didn't kill her. Think about that one.
What'd you say?
I didn't say that part, but I did explain to her that CYP1B1 converts 1,2 to 8,16, and she said, I did say that. She said, oh yeah. I was like, shouldn't you be testing this on every patient taking birth control? Think about that. What are we doing to people? CYP1A1 converts E12 as protective. Catecholamine O-methyltransferase, we saw that before. So SNPs means reduced function, lower productions. Follicle stimulating hormone, that's hair. Yes, ma'am, hold on. I've got a microphone just for you because we are recording this lecture. Hold on. Let me hand that back to her. Oh! And you're not going to be heard over this, you're going to be heard on that, on my recording.
Can't follow that. Oh, it's no microphone anyway.
It's okay. It's for this, not for...
Oh, okay. So my question was on the cancer risk for female cancers. Is it breast cancer or uterine or which cancers?
I don't know which one.
Oh, don't know.
So the question was, what is the risk
Yeah.
for female cancers? Is it breast or uterine or something other? I don't remember which one. I don't think it's breast. That's a HRT2 or something like that. The aromatase one. Thank you. That's a pretty good catch. All right. Where am I? CYP119A1 converts androstenedione to testosterone and estradiol. Higher levels of estrone and estradiol, associated risk with endometriosis and estrogen dominance. Consider an aromatase inhibitor or diendomethane. That's a supplement that you can get that helps you to convert those things. My wife is in her mid-40s, and we're having some issues with hormones, and she started taking diendomethane because she has a CYP19A1, and those hot flashes just got so much better. It was very, very nice. And not everybody responds to that if they don't have that gene. So it's better to know what they need and give it to them than not know and try this, try that. That gets on my nerves now. Okay, so autophagy, getting rid of intercellular garbage. Hour in, good. Poor autophagy equals type 2 diabetes, neurodegenerative disease, cell death, cancer, innate immune system problems, cardiomyopathy, aging, infectious disease, fatty liver, macular degeneration, glaucoma. These are all things that come from problems with autophagy. So there's a bunch of different categories of those. You got your ATGs. You got an ATG 5, 12, 16, L1. That's a protein complex that forms the wall of an autophagosome. You got your SMRFs, Hirano bodies of Alzheimer's and colonic carcinomas. So if you have a SNP there, you get weak autophagosome initiation. You got a NOD2 and a CARD2, lower ability to clear bacterial antigens. And then you got the PARCs and the pinks. PARC1 is autosomal dominant, slow progression of disease. Autosomal recessive, ubiquitin ligase, early onset of Parkinson's. slow progression. Your Part 6 is autosomal recessive mitochondrial late onset problems. So, APOE, that's called intermediate density lipoprotein, blah. Principal cholesterol carrier for the brain. We got to have cholesterol. Cholesterol is an important part of our body. It helps us to convert D2 to D3 with sunshine. So we got to have it. E4, there's an E2, E3, and E4. If you have an E4, it's correlated with Alzheimer's and atherosclerosis. Okay, so this is interesting because I was watching a video. You guys watch MedCram on YouTube? Highly suggest you watch that.
What is it?
MedCram on YouTube. The guy, Sinholtz or something like this, and it's basically a review of studies and that kind of stuff, and it's a 15-minute usually, and it's current topics, and it's just cool stuff. The reason I put this in here is because my wife loves to go to the tanning bed and get near IR, infrared light therapy. But near infrared light reduces inflammation through the TLR4, which reduces SARS-CoV-2. That's pretty cool. Toll-like receptor 4 activity decreased with near infrared light through your innate immune system. And then they go through and they show all the studies for COVID-19 and how to reduce it. Near infrared light relieves TLR4 dependent hyperinflammation of the type induced by COVID-19. Here's a study, here's a study, here's a study, here's a study. Pretty cool stuff. So genetics is exploding. And there's a ton of things that we can go through. And I think I've got enough time to show you some of the studies and show you some of the things that are going on in genetics. And here's one. That scared me. Intracellular reverse transcriptionase of Pfizer BioNTech COVID-19 mRNA vaccine in vitro in human liver cell line. One of the things that they talked about for the COVID vaccine is that it stayed at the injection site, and it created the response from the injection site. But what they are now finding, and this was when they released this, and this is current issues in molecular biology, so it's not some kind of off the beaten path. This is February of this year. Recent studies showed that SARS-CoV-2 RNA can be reverse transcribed and integrated into the genome of human cells. Okay, so if we see all of these intricate pathways and intricate things that have to happen sequentially in 100,000 processes in every cell of your body all day long, and then we go in and we change that DNA in your body, what have we just done? We haven't changed one process. We haven't changed 10 processes. We have changed 100,000 processes, potentially. Okay? Now, this was another one that I just found just the other day. How many of you eat natto? How many of you know what natto is? How many of you have lived in Japan? Okay, that's what I thought. About 5% of the population in Japan eats this stuff called natto. And I call it nasty because it is fermented soybeans. Okay, and they eat it for breakfast. And it's like a really bitter, it's like a fermented, like a rotten soybean, you can imagine. But what they found is that the people that eat this on a regular basis didn't get COVID.
Nobody get close
because nobody would get close to them, right? Well, maybe so, but here's a more likely reason. Not that that's not true. Degradative effect of nattokinase on spike protein of SARS-CoV-2. Pretty cool. So what they found, and see if I highlighted it. Maybe I did, maybe I didn't. I think I remember what it said exactly, but not for sure. Anyhow, it degrades not just SARS-CoV-2, but coronaviruses in general by binding to. It initiates receptor binding by interacting with the human host cell angiotensin converting enzyme 2, the ACE2. You guys remember that for hypertension? Angiotensin converting enzyme, okay? Your ACE inhibitors, all right? So we know who will respond to that by doing their genetics, okay? So if you have that, you probably responded to COVID more than other people, okay? But ACE2 enzyme and the S2 subunit participates in viral fusion with the target cell, and it binds and removes the spike protein. So I have had COVID several times, and I started taking nattokinase when I read this study about a month ago, probably. And I started taking nattokinase because I wanted to get rid of SARS-CoV in my body, and I don't know that I've done it. I don't know that it works, but according to this paper, it's a pretty good remover of all coronaviruses. So not just SARS-CoV-2, MERS. What are the other ones? There's a bunch of them out there. So anyhow, that's a big deal. Well, that's how it works. May inhibit plasminogen activator PA1, which leads to fibrinolysis, reduces clotting, and degrades viral spike protein on the cell surface of cells. I did write it down. It's right there. I should look at my own stuff. All right. So I'm going to go back and show you, I've got enough time here. Got about 20 more minutes. I'm going to show you a couple of things on me for my my drug interaction genetics. And there are some company, yeah, that's me. There are some companies that do all of your genes. This company only does it for those that we know the pathway, and this is scary to me. We know the pathway of the pharmaceutical product. Think about that one for a minute. We know the pathway of the pharmaceutical product. We know how that product, how it goes in the body. Okay? This is by no means all drugs. Okay? So, they test APOE, COMT, CYP1B1, and they divide it into, are you an intermediate metabolizer, an extensive or ultra rapid metabolizer, which means drugs probably aren't going to, you have to have double the dose or triple the dose or whatever, if you're extensive or ultra rapid. Intermediate metabolizer, I'm a poor metabolizer of CYP2D6. I'm also a poor metabolizer of CYP3A5. And then there's a factor 5 and the MTHFR. And so what they do is they go in, and these two. So they look at a bunch of genes, and they look at the drugs, and they say this drug affects this pathway. So in the category of cardiac drugs, antiarrhythmics, flecainide, and propafenone, what that means is that I have statuses that they aren't sure about, so we don't know if that drug's going to work good or bad for me. It's one or the other. We don't know which one it is. Anticonvulsants, phenytoin. Here's where I got that clopidogrel and prasugrel. Antiplatelet agents, change recommended. I don't process clopidogrel. I do process prasugrel. So if I go to the hospital and I've had a stroke, I'm going to tell them, give me prasugrel. Let's not try clopidogrel. I might die. That's a good thing to know when you're going in the hospital, right?
On the standard precaution side, it means you shouldn't be taking them?
No, standard precaution. Here. He said on the standard precaution side, that means you shouldn't be taking them. No. Standard precautions means you process that drug normally in your body. You can take that drug without any concerns of buildup or it not working. It works. It should work like it's supposed to. Okay? That's what standard precautions are. Antidepressants. Notice that this is under gastroenterology. Think about that one for a minute. Antiemetics, endocrine metabolic agents, nonsteroidal anti-inflammatories, proton pump inhibitors, SSRIs. I shouldn't take paroxetine. I can take citalopram. Antifungals, anticonvulsants, mirtazapine, meclobamide are fine. Amitriptyline's no good, or it's, be careful. Clomiprine, desmoprine, doxepin, nortriptyline. Here we go. Muscle relaxants, carisoprodol will send me into cardiac arrest. Don't take it. Doc, let's not try that drug. I don't want that one. Thank you. Tramadol. Let's not take that one, Jason. SSRI inhibitors, fluoxetine, fluvoxamine, paroxetine, and sertraline, don't take. I can take citalopram and escitalopram. I'm good with those. Thiridazine, don't do it. Olanzapine, no problems. Here we go. Dextromethorphan, quinidine, that's what I was trying to think of earlier. And then the cool part about this report is they actually label each drug with, we have strong clinical evidence, we have moderate clinical evidence, or we have emerging evidence. We think this is the path. We know that this is the pathway, but we think it affects it this way. So we got good evidence for I shouldn't take tamsulosin Flomax. We have moderate evidence that I shouldn't take Aviccio and Asdeniz, whatever that is. I should not take Strattera. I should not take Focalin. Let me get to one that's emerging. There we go. Warfarin. There you go. There's a biggie. Individuals with the variant CYP2C9 genotype have increased risk of adverse drug reactions after initiating or discontinuing NSAIDs. Check INR for more frequently. So we're going to check to see how my reactions are to this drug much more than we normally would. Yeah, no. These are very common drugs. Yeah. Half this class is maybe on statin medications. Are statin medications okay for you? Why do you have that inflammation in the first place? Where does it come from? It's not normal to have high cholesterol. It's either environment induced. I sit around, eat too much, drink too much, want too much. Dave Matthews reference, if anybody got that. Or I exercise too much. That's the other side of it. That used to be me. I used to do triathlons, bike racing, and I found out that I can't do all that stuff so much. And then, there's standard standard loading dose, but then reduce maintenance dose by 25% on phenytoin. So we've got the information about how to do that. If you really think I need this drug, we can take phenytoin, standard loading dose, reduce maintenance dose by 25%, evaluate response and serum concentration after 7 to 10 days, be alert to ataxia, nystagmus, dysarthria, and sedation. All right, so now we know if I have to take this drug, what are the potential problems and how do I deal with it? It's brilliant stuff. All right, we got about 10 minutes, 20 minutes, sorry. We got 20 minutes. Questions, let's do 2 microphones. Oh yeah, I'll start right here.
Okay. So my question would be about implementation. Like, how did you choose which company you wanted to use for testing? How do you know if insurance will cover it? And then how do I bill for it?
Yes, those are great questions. So, the reason I chose the company that I am using, GX Sciences, is because I've known Kendall Stewart for over 20 years. I told you he's the smartest human being I've ever met in my life. Photographic memory. He's a serial entrepreneur. He has started at least 5 companies that I know of. Multi-millionaire, brilliant guy, neurosurgeon, specialist neurosurgeon. I've been to, 20 of his lectures, and I trust everything that he says because I don't trust anybody, and I go back and I check. Don't trust me, okay? Just because I'm standing up here doesn't mean I know squat. Go back and do the research yourself. Dig in, figure it out, understand it. There's companies that will do every gene in your body. They will sequence your whole genome. $5,000, $6,000 cash right now, okay? The testing that we do is 107 enzymes or genes, sorry. I say those back and forth. We charge about $600 for the test. It's cash only. And I've done just under 400 of these tests, 400 patients with this, and the results are unbelievable. Type 2 diabetes gone, hypertension gone, high cholesterol gone, fatty liver disease gone, polycystic ovarian syndrome, migraines. I've got 7 patients that we have had a reversal of macular degeneration. If I get to 20, I'm going to publish. And we're talking OCT measurements, not me looking at it going, oh, yeah, it looks better. We're talking macular thickening that has reversed. Now, once you get to geographic atrophy and stuff like that, I don't think that there's a whole lot that you can stop progression, I think. I don't know that because I haven't had that yet, but I know that I've had the macular thickening that has reversed. That's a cool thing. Type 2 diabetes. When you get patients that are getting ready to get on 2 or 3 meds from their doctors, and you go, hey, try this, see what happens, and they come back 6 months later and go, I'm on nothing, I'm feeling great, everything's good, my numbers are great, my doctor says I did a fantastic job with all my exercise, and they didn't really exercise. It's a good thing.
What's the process for
Everybody wants to know.
Okay. What's the process for getting the samples, or how's it done?
Oh, good question. Good question. Cheek swab. Put it in a sample. Send it off to a lab. 10 days later or so, we get this big report. Here, I'll pull up my report so you can see it. We got enough time for that. That's good.
What's the cost on that?
Cost? To me or to you? I've been with them for a long time. It's about, I'm going to say it's about 350-ish. We are currently, that's why I'm recording this right now. I'm currently working with them to get a specific ophthalmic panel that'll be half that cost, but it'll hit all of the genes that are affecting, there we go. I'm going to do mine. All the genes that are affecting specifically the eyes. And we've actually found, yeah, I can say this. We've actually found the 2 of the genes that are responsible for posterior capsular epithelial ingrowth. And we think we can stop it. So here's the overall on that. You got these genes that when you have epithelial cells that stay in after cataract surgery, 15% of the population, they regrow. You got to have a YAG, $300, whatever it is for a YAG per eye, and I don't know that's the price. But if we can determine through a $50 test who's going to have it, who's not, and then stop it in those who it would happen to, we just save Medicare $3 billion a year. That's a big deal. That's a huge deal.
Some of those Will some of those tests tell you what enzymes or supplements you need to take to?
It's exactly what they tell us. Okay, so right now, the 107 that we test are things you can actually do stuff about. Okay, the biggie, for me, is the palmitoyl ethanolamide. Okay, I'm putting every glaucoma patient I got on that because why do they have glaucoma? Because of neuroinflammation, increased pressure, blah blah blah. We take the palmitoyl ethanolamide, we decrease their pressure, and we protect, give them neuroprotection. We know that, okay, so that pathway is actually called an endocannabinoid 2 receptor. Yeah, I didn't say this before, did I? About the CBD? Okay, good. All right, so CBD oil, whoop, whoop, whoop. Everybody, CBD, whoopie-doo, okay? It's the magicness, right? Okay? Genetically, endocannabinoid receptor, it is 2 to 3% of the population. So for the 2 to 3% that don't have endocannabinoid 1 receptors, CBD is the miracle that they say it is. It affects hormones. It affects mood. It affects, specifically affects the immune system. So those are the people that CBD is the miracle. 2 to 3%. That's what CBD hits. Okay? Palmitoyl ethanolamide hits 25% of the population. Those are endocannabinoid 2 receptors. Okay? Some people require both. That hits a lot more, actually. So it's super interesting to me because of what it is. CBD is this stuff that everybody thinks, oh, everybody should have it. Well, no. Only 2 to 3% of the population should actually have CBD. And we can tell you who it is and who it's not. So it makes a big difference in what you're doing for people. Do you still have a question? Yes. Hold it, Jeff. No. We got to talk straight up. I got to get it for the other one.
You mentioned you had done this on 400 patients. Why not everyone in your practice?
They can't afford it. I would do it for everybody if I could.
Why doesn't insurance pay for it?
Insurance doesn't pay for it because it's health and wellness. It is not disease yet. Okay, this type of thing has only been out for about 4, 5, 6 years. Like I said, we started with 24 genes 8, 10 years ago. We went to 36, and we went to 58, and we jumped to 107. We're, the inherited retinal disease, 317 genes. And that's just your risk and your kid's risk for getting this. And when I get positives on those, I send them to a genetic counselor because I don't know the inherited retinal disease stuff. But the health and wellness, because it's health and wellness, they don't pay for that yet. If they figured out how much money it was going to save them, they would pay for it in a heartbeat. So, yes, another question.
I'm actually looking at your GX Science
Website? Yeah.
And so it's got like a comprehensive panel. Also,
Mm-hmm.
it's got TBI, wellness, different programs to pick from.
Yes.
So are you going, it's got 15 different panels of categories?
Yes.
So you got your own customized one? Is that what you've done?
I
at the
do
bottom?
now.
Okay.
Yes. Okay. So I generally do the 107, and then I will add a SNP, a test here and there. I think it's like 15 or 20 bucks to add a single gene. Okay. So they do your whole genome. They only tell you about the 107 that we can do stuff about. Okay. So a prime example is 10 minutes. Okay. Prime example is a gentleman who's a CEO at a company. He played college football. He's 6'4". He's 300 pounds. He is your hyper aggressive, get it done, take care of business kind of guy. Started getting some confusion at 50 years old. Started getting confusion and started CTE, chronic traumatic encephalitis. Played football in college. We did a full panel on him, and then we added a couple of genes from the concussion panel to, clarify which areas he was having difficulty with. He takes that full focus every day and a bunch of other stuff, but he takes that every day, and he said, man, I am on top of my game. I'm back in a business, man. I love this. And it makes a huge difference in his world, because he's got to be on top of his game all day. He's actually CEO of a company that produces pharmaceutical packaging. So he works for, no, I can't say that. He works for companies, he makes packaging for major pharmaceutical products. Okay, any other questions?
What's the name of that lab again?
Okay, the name of the lab is, and I'm not promoting them, they're just one of, there's probably about 10 of them right now in the United States that do this. The one I use is GX Sciences. I am not paid by them. I'm not a spokesman. I just use their product. There's XRMD. That's the ophthalmologist out of Ohio. He does a little bit more specific for ophthalmic stuff. Any of you guys know Scott Sedlak? He's on LinkedIn and he's on Facebook a lot. He's an optometrist that does this kind of stuff. He does a lot of genetic stuff. He works with XRMD all the time. So they're a good company. I just switched from them years ago when they had a lot of trouble about 5 years ago, and I just decided, I didn't know that Kendall Stewart was doing this. And when I found out he was doing it, I'm like, yeah, I'm in. So, all right. I'll get you first.
I think you mentioned this a minute ago, but just you get the results back. Does it tell you which supplements to take? And
Yes.
Then we have to figure
Yes.
out how to get them.
Yeah.
Where to get them from?
You said
So,
it had to be a third party.
Their third party is called Neurobiologics, and I sell supplements through them. They're third party AGE certified, I think it's called AGM. I can't remember which one it is, but it's a third party certification for absorption in the body. Very nice stuff. He addressed it. Okay, so the supplements are average priced and obviously high quality because they're absorbed. I got accused of being what they call it, one of the primary care doctors in town called me it wasn't that. It was like a entrepreneurial opportunist. I'm like, well then, tell me how these studies that you didn't read. Tell me where you read that. Did you read these studies? Have you looked at this genetic stuff? Because if you haven't, shut up. Honestly, I get tired of doctors who know saying, don't do this. I'm like, well, what did you study about this? Well, I haven't studied anything. Supplements are bad, right? And they can be. Some of them may be. Don't take a bunch of stuff you don't know works. Yeah, you can go by outcomes. I feel better. Yeah, okay, that's probably working for you. Or you can go by hard science and go genetics. Yep, you absolutely, no question, have a problem with that. Let's take care of it. So it's a big deal. I think in the next 15, 20 years, genetics is going to be it. Because it's specific medicine for you. For me and for you, and it's different for you, and it's different for you, and it's different for you, and different for you. So, all right, well, thank you guys for listening, and I appreciate it.
I can just grab this one. Thank you. QR codes are ready to